All right, so are you all able to see the screen which says, wait, Royal College of Physicians of Ireland membership exam? Please let me know if you are able to see this.
No, Dr. Uzma, you will have to share it again.
I have to share it again. Okay, I'll
Yes.
do that.
Yes, now it's visible.
Now it's visible. Okay. All right. Okay. So, what is our aim is to ace the MRCPI OSCE in one go. We don't want you to, waste your money again on this exam. So whenever you're planning to sit, prepare well and pass in one go. And it is very much possible, MRCPI. It is not a difficult exam, but it needs very well preparation. That is all. So we are here to guide you how to get ready for that exam day, how to prepare yourself for the long cases, for the OSCE stations, what is expected out of the candidates in MRCPI, what the Royal College expects you, what is the standard they want to maintain for their membership. So that all, we will try to, we will have a series of free webinars, hopefully. And our course also will commence, as I said, in August, where we will be teaching in detail how to prepare each station, because in our course, we will be covering most of the previous exam stations. So that is a big help, because you feel that you have done this before, and it becomes very easy once you feel that something which you are prepared for is being asked again in the exam, so you know how to go about it. And in our course, what we do, we don't go exactly as if, puppets of the recalls. We prepare you for the topic. So whatever way that topic comes, you should be able to handle it. Even if there is a small glitch here, glitch there. So you should not get, oh, this was not expected, but you are prepared. Your topic is ready. So once your topic is ready, this way or that way, you have the knowledge and you can answer any question. So this is very, very important. So as you know, this exam, it is going to come, yeah. So the next exam is in 1 minute. So next exam is in Dubai on 9th and 10th of November. Of course, the seats will be confirmed later. So it does not, as it says, it does not mean that you apply first, so you will get your seat is confirmed. It doesn't work like that. It is the college who decides who will sit for the exam, and you will only pay for the exam once your seat is confirmed. And if you are not getting a seat in this exam, then you will be put on the waiting list. If somebody cancels the exam because there are people who are not able to, go for the exam for one reason or the other, they cancel the exam and then the college again offer the seat. So that is why stay prepared, not only with the visa, but with your preparation. Both the things are very important, especially people who are coming from Pakistan and places where visa is a problem. Now this is in Dubai, so hopefully it will not be a problem, but still stay prepared. Don't, run in the last days for visa and other things, because last week, 10 days is just to be focused on your preparation for the exam, not here and there. So it's very important to stay prepared both ways, for traveling and for the exam, of course. And then you cannot, as they say, you can apply to only one location, either UAE or Ireland. And it does not mean if you are sitting in UAE, you have better chance of passing, or you are going for the exam in
Sorry, Dr.
Ireland.
Uzma, there are a couple of candidates waiting. Can you please admit them?
I have to admit again.
Yes, yes, yes. Now you are host again.
Okay, okay,
You are in charge.
okay, done.
Okay, thank you.
All right, welcome everyone. Okay, so this message, whenever it will come, I will admit. Okay, fine, I'll do
Yes,
that.
yes.
Okay, so many people say, especially for our MRCOG, they will keep asking that, is it better to come and appear from UAE rather than going for UK, because the chances of passing are more in UAE? No, it is not like that. We all sat in UK, we passed our exam from UK, although we never worked in UK. Okay.
मेरी दोस्त से पहले मुझसे पहुंची हूँ.
Sorry.
Someone's mic is on.
Please keep your mics muted. All right. So, the Osce clinical exam, it tests your knowledge and understanding of obs and gynae. It has problem-solving skills, investigations, treatment, clinical, and communication skills. It is a gateway to progressing to higher specialty training and ultimately a career in hospital medicine. Okay, so as you know, the exam itself has one long case and 7 short cases, or we call it OSCE stations. So the long case is for 25 minutes, which is fully observed station. There are 2 examiners who are sitting right at the backside of the role player. There is no real life patient. It is all role player. Okay, so the setting also is not inside a hospital. It may be some adjacent to the hospital, but not in the ward or any other place. It's not a real patient. It's just a role player station. 2 examiners will be sitting right at the backside of the role player, and they will be quietly listening to your conversation between you and the role player. So in the long case, you are expected to take a detailed history. It's a 25-minute station. So you have a lot of time. So please, unlike MRCOG, don't rush into the history. Take a detailed history, okay? There are marks for each and everything, starting from presenting complaint, history of presenting complaint, obstetric history, menstrual history, past medical history, surgical history, each and everything, there is mark for it. So please make sure you are touching each and everything in the template of the history. So once you are done with your history, you are supposed to do an examination on a mannequin. So mannequin is there. If it's an obstetric case, then you're supposed to perform a general physical examination in all cases, be it a gynae case or a obstetric case. So a general physical examination you will perform, and then you will perform a obstetric or a gynae examination. Okay, and after you are done with your examination, you will brief the case to the examiners. They will say, okay, can you just summarize the case? And after that, the discussion will start. So the discussion will be about your diagnosis, then what can be the differential diagnosis, then the management. Management will be in terms of investigation, treatment, follow-up plan. Okay, am I clear so far? If there is any question, please feel free to ask me. Next exam, who is this next exam? I don't know about FCPS, but yeah, this is MRCPI. I'm not sure, maybe Zeb can answer this better because I'm not into FCPS. Okay.
Yes, I mean, it's a kind of like FCPS, but it's not like exactly like FCPS. But somehow, if you have done FCPS from Pakistan, so it is surely going to help you in MRCPI, because in MRCPI, you also have to do the examination, you also have to take history, you also have to present case to the examiner, and then there is going to be discussion. So more or less, it is similar to long cases, okay? But I think in FCPS, they have taken down those long cases as well, isn't it? So now they do have the extended talks, if I'm not wrong. Okay, so yes, if you have done FCPS long case, so yeah, it is going to help.
Yeah, and plus, because I am a very oldie goldie, so I cannot comment on FCPS currently. I did my master MCPS in 2003, so that is, very long ago. And that time there were real patients. I don't know if they're bringing the real patients still in FCPS or
Yes, yes,
MCPS now
yes.
or
They are,
no.
they are they are still bringing the real patients. Yes, even I had my exam, back in 2015, but we had with long cases and real exam patients.
Yeah, so I think in there in Pakistan it's possible, but here in MRCPI, There are no real patients. You are supposed to perform the examination on the mannequin. So just practice yourself. The general physical examination is just verbal examination. Okay. So if you have a patient of cancer, they expect you to talk about the BMI or a weight loss, or if the patient is coming with nausea, vomiting, you are supposed to, talk about the hydration status. If the patient is coming with the PCO, then you have to talk about if there is any hirsutism or no. That you will get once you are taking the history of the patient. So the patient says that, okay, I have this hair growth. So once you are doing examination, they expect you to talk about that. So, relevant physical examination is very, very important. The general physical examination and the relevant physical examination that is expected from whatever diagnosis you have in your mind. Okay, am I clear? Okay. So this is about the long case. Then you have Osce stations. In UAE, how they are doing, they are just not cubicles as such. It's a corridor. Sorry, your voice is broken. Couldn't hear you. So yeah, you will do examination on mannequin. Yes, Sandhya. You can write if somebody asked something, I didn't get it. Okay. All right. So for the Osce stations, you will be standing in a queue. Okay. So 7 people will go in one cycle. So you will start with your station. There is no separate reading time. You have just 10 minutes. And once you will sit at the station, same time you will see your task. Okay. Take your time to read the task, and then 10 minutes are more than enough for that task. Okay. Sometimes it's very long, 10 minutes. And once you are done with your task, they start talking about, general things not related to the exam. So the task will be there and the examiner will be asking you a series of questions as per your task. And once the bell rings, you have to move and stand again in the queue. There are 2 minutes waiting time in that queue. That time you are just standing doing nothing, but the examiner is giving you marks. Okay, so this is how it goes. And every 10 minutes, 2 minutes rest, and then again you go to the next station. But that 2 minutes is just rest, nothing else. You're not supposed to, read or do anything in those 2 minutes. Then there is a rest station in between those 7 stations. Not each time we saw a rest station. Sometimes they're keeping that rest station. Rest station means there is no task in that. So you are just sitting for those 10 minutes and then you go to your next task. Once you finish with your 7 stations, khalas, you are done with your exam and that's it. So this is how the exam goes. No, you cannot drink or eat anything. Inside the exam, the hall, you are not expected to drink or eat anything. Okay, you're just supposed to stay prepared for the next station. I don't think while, in that circle, when I was going through that exam, at least, I was only reciting something from the Quran because it's very stressful situation. I don't know how it works with you people. Everybody has a different approach towards exam, but for me it was very stressful. Although I already passed MRCOG EPCOC exam, but still the exam is a very stressful situation. You always keep thinking, okay, what is going to come next? I don't know, Zeb, how you felt once did you feel like eating or drinking?
No, absolutely not. It was such a stressful situation, and I still can recall because I was in Dublin at that time. So, the first of all, I had to, the travel to the exam center, and then I had to walk for like 10 to 15 minutes because college was, I mean, I don't know where on the, I mean, which corner of street, this and that. So, it was kind of troublesome for me. And by the time I reached to the, the exam center, so they were taking attendance and they were just pushing candidates towards the 14 candidates to the Osce room, and 14 stations 14 candidates I think to the long case room. So, somehow the like this, because they were taking 2 batches on my exam day. So 7 in one Osce room 7 in one long, the case room, then 7 in other room. So this is how they have managed. So it was very stressful for me, trust me.
Yeah. So Razia, please don't think about eating and drinking. Just think about exam. After that, you can drink and eat anything you want. Okay. All right. So what are the examples of the topics that are asked in the MRCPI exam? There are some typical topics which keep coming again and again, at least for 5-6 years. This is what we are seeing. Obstetrics, there's a famous case of PPROM. Earlier, the exam used to be in the hospital on the real patient, so they expect you to, give the demographic of the patients, when the patient was admitted, what investigations were done for the patient, what treatment was patient received already. So now, since it is a different setup, it's all role player thing, simulation, so it's different now. But there is these are the common stations which I've just mentioned here. Of course, once you take a course and go into the details, all the stations will be covered there. So you have a station of a large for gestational age. MRCPI is a very tricky exam in the sense that, okay, you might feel that, okay, this station is about only large for gestational age. But in between, there will be too many things, additional to it. So if you are going for large for gestational age, you have to stay prepared how to manage polyhydramnioles, how to manage GDM, how to manage postpartum hemorrhage. So, anything which is connected to the large for gestational age fetus, starting from what can be the causes of LGA baby and how this baby will be delivered, what are the possible postpartum
हाय
complications.
बाकी 10 बंदे कहाँ से पकड़े हैं?
Sorry. Please keep your mics
जो
muted.
आज आई हुई थी काम वाली हिस्ट्री वाली, इसका फोन नंबर है?
Excuse me, please keep your mics muted. Thank you. Thank you very much. Okay. So, yeah, what we were talking about, LGA. Am I audible, girls? Hello?
Yes, dear.
Yeah, okay, thank you. Yeah, okay, so if it's a twin pregnancy, of course, it will not be a straightforward twin pregnancy. It will be for sure a monochorionic, monoamniotic, or a monochorionic diamniotic pregnancy. Plus, they can, start with, if maybe it is a IVF pregnancy, they might ask you questions about IVF, about complications of IVF, about ovarian hyperstimulation syndrome, then how you will manage this twin pregnancy, what will be the mode of the delivery. Then they might say, okay, one is now growth restricted, so how you're going to manage. So, it's not just about twin pregnancy. It will be so many other things which they will try to cover with this twin pregnancy. It is not only in long cases, this happens in the Osce stations as well. Then pregnancy with CIN, how you will manage the CIN. This is again a very common station which keeps coming again and again. Then pregnancy with autoimmune problems. Autoimmune problems, they can be rheumatoid arthritis, it can be Sjogren syndrome, it can be SLE. So the baseline, they have a new guideline in 2023 about the autoimmune diseases. So what they expect you to have a general understanding on how to manage these patients, be it with SLE or Sjogren or rheumatoid arthritis. The basic management remains the same in a pre-pregnancy setup, in a antenatally, how you will manage, intrapartum, what you will do, postpartum, how you will manage. So this is all is written in the guideline, and if they have a guideline on certain topic, they want you to talk about their guideline only. So please, whatever topics are there covered in their guidelines, prepare from those guidelines. Don't go here and there, just stay prepared with their guidelines. Then there can be fetal anomalies. This is also a repeated station which keeps coming. They will show you a picture of ultrasound, and you have to diagnose what is the anomaly. And then according to the anomaly, they will take the station. This is a Osce station. It keeps coming again and again. Then there can be labor and delivery complications. There can be labor ward prioritization. This is what they call clinical simulation. So there is no real, they will not provide you with any forcep or vacuum or anything to do. They will just create a scenario in front of you, and then they will tell you how to manage. Most likely, it can be a breach in labor, or it can be a postpartum hemorrhage, or it can be a fully dilated patient. Now, how you will manage? They will ask you verbally how to apply a vacuum. Please keep your muted.
Dr. Uzma, you can mute all of them.
I can mute all of them.
Yes.
How?
Yes, you will go to the names and you can mute all of them.
Okay, sorry, I have to do this because 1 minute, I'll do that. Mute all.
Yes.
That will mute
Yes,
you
yes.
also.
Yes.
But you will be also muted. Is that
Yes,
okay?
yes, no problem, no problem. Mute all.
Okay. Alas, fine. All right, girls. Sorry, I had to do that. This is for your benefit, because if somebody is talking from behind, you cannot understand what I'm telling. Okay, so then we were talking about labor and delivery complications. So the labor and delivery complication, as I said, it can be labor ward prioritization. It can be a fully dilated patient where you have to apply a vacuum. So they will give you a scenario. It can be a primary gravida with a high head, which place you will apply the vacuum, how you will apply the vacuum. And then, of course, second stage cesarean section, they expect you to know, verbalize the steps of second stage cesarean section, what are the complications. Then they will make you manage the postpartum hemorrhage. So this is how this clinical scenario works. Then gynae cases are malignancies. Each year you see ovarian cancer patient, case, endometrial cancer patient, endometriosis, polycystic ovaries, ovarian hyperstimulation, subfertility case, and the patients with amenorrhea. So, and then there's a famous repeated question about Turner syndrome. So, most of the things are repeated. So, if you are there, if you have prepared, my God, I muted everyone. So, how come? All right, now muted. All right. So these are the few examples of the stations which are coming in each MRCPI exam. So today, what we are planning to do, before that, anybody has any question can write in the chat box. I don't want to open the mic because then there will be problem. Because today what we are planning is to do one long case which came in the previous exam, and Osce station that again came in the previous exam, the May exam. Okay, yeah, mostly they are doing the, in Dubai, how it works, Sandhya, they are finishing the long case first because they are bringing two batches. Each batch is, I think, 18 or 28 candidates. And they will take the candidates first batch, the morning batch first, and they will start with the long cases. Once they are done with the long cases, they will take the second batch and finish with the long cases again. Okay, so then there is a gap of 1 or 2, because the first batch who finish with the long case, they will sit and wait. Okay, then once the second batch is done with the long cases, then they will start the Osce station for the first batch. So in that time, the second batch which just finished a long case, they are in the waiting area. That time you can eat, drink, relax, no, whatever you want to do, you can do, because it's a 2 to 3 hours break time. Then the Osce station start. This is how it goes in Dubai. I don't know how it goes in Ireland. Maybe Zip can tell.
Yes, yes, it is almost same, Dr. Uzma. Because
Mhm.
the 7 stations, because I remember I had my 7 stations OSCE first, and then I had to wait in the waiting room for I think next half an hour or so. Then I had my long case. But my, the friend who traveled with me, she had long case and then she had OSCE, vice versa, 7 7 each.
Yeah. So this is how it goes. Okay, Sandhya? So anyways, it does not matter how the OSCE stations are there first or the long cases first. I mean, you have to do all of them this way or that way. So just stay prepared for it. Okay. So marking scheme. Marking scheme is with the examiner. Marking scheme, of course, I cannot share with you any marking scheme right now.
Yes.
But once you are doing a course, then that time we will tell you. Now we will do some station, as I said, a long case and a OSCE station. And I want two volunteers, please, if you don't mind. And please don't be shy. It is just a free webinar. It is just to help you and guide you. We are not judging anyone over here. So especially people who are keen to sit for the November exam, please volunteer so that you can do the station. And once we will discuss that station, that time I will tell you what is expected out of you in that station. Okay. So that will be your marking scheme. Okay. So can I have a volunteer for a long case, please? You can write in the chat box. No one want to do it? Come on. I would love to, but don't know. What do you mean you don't know anything about exam? I just explained you, Sandhya, no? Okay, sure. Anybody else who want to present? It is just webinar. As I said, nobody is judging you. And believe you me, once you will perform here in front of people, it will boost your confidence. Okay? And you will have that energy to go for the exam.
Come on, guys. Amal,
But
Anam,
so many people are here, but still no one wants to
Rabia,
take.
Aisha, Manikam, Nimra, Umama, Razia, anyone? I think Razia is in clinic.
Razia is in the clinic, she cannot do it. And
Yes.
Sandhya is saying she has. But we have
Yes, I
so
know
many other
her.
people.
Yes, I know her personally, and actually, she hasn't started her preparation. So I invited her today just to have the quick overview about this exam. So, yes, perhaps she will present in the next.
Come on. So many people are there. Me and Zabe cannot do the station, no? Because
Otherwise, that is going to be the last resort. Just to present.
it's fine. So many people are there. Who is this Samsung? Umama, Noora, Noor Khan. We have so many with Noor. Is this the same person or
No, our meeting is Purnur today.
it is Noor, Noora, Noor? I don't know if they have the same people. Nobody want to take the task. What is the benefit of this webinar if you people don't want to get this uh, feel of exam?
Don't know, still, I mean, everybody is so shy to, the present and to talk about and to present. Even yesterday, I had, a lot of difficulty because not everybody was, the, like, I mean, kind of ready to present task. So,
Mm.
guys, come on. Anyone?
Assalamu alaikum. I just joined the meeting. Can you please repeat the question or task? What are you asking?
We haven't even displayed our questions. So if you are interested, I will display for you. You can take the task.
I can try. Can you please
That's
display?
Very
very
good.
well done.
Very well
Okay,
done.
Maham, we have a volunteer. Very good, Maham. I really appreciate. Okay, let me just. Okay, this will be a long case, Maham. Okay, So when are you planning to sit for the exam?
I'm not sure yet. I'm just to start preparation for this, and then when I feel that I'm prepared, then I will take the exam.
Oh, that's good. But you have an idea of the exam, right? A long case and a OSCE stations, right?
I'm not yet.
Not yet. Okay, so I'll just repeat myself because we
Yes.
already discussed a long case and a OSCE station. So the long case is about 25 minutes. What we are going to do now is a long case. In that long case, you're expected to take a detailed history, okay, perform an examination on a mannequin, and then discuss the case. Okay?
Okay. Okay.
All right. So this is your case, and 25 minutes is total time you have, all right?
Sure.
Okay. Yeah. So can you see the screen?
Yes, I can.
All right. Okay. Okay. So your time starts now. When you are ready to start the station, just let me know, okay?
Okay.
Hmm? Okay, Maha?
Yes. Okay. Okay.
All right.
I will let you know.
Sure. It's all going from your 25 minutes, okay?
Yes. Thank you.
Maha, what happened?
वो पीछे से यार ये बिल्कुल पहले ही मेरे पास बहुत पुरानी तो वो मैंने ऐसे किया वो तो हो जाएगा उसके बाद वो या तो सब या तो
Maha, are you ready? Are you still with us? I think. Yes, Maham, at least confirm you are still with us. Otherwise, we will ask someone else to do the task. I don't know. I don't see her name here. Maybe she got disconnected. No, she's still there. Maham, please answer if you are ready to do it or no. What shall we do, Zaid?
I think ask some other candidate.
Yeah, because she's not responding. I don't know. There is some problem at
Ma'am,
her
shall I
end.
do, ma'am? Monica.
Monica? Yes,
Yes, ma'am.
Monica.
Yes, ma'am. Hello.
Okay. Yes, Monica. So
I'm
we'll start.
Monica, one of the doctors in the clinic today. May I check your name and age, please?
Hello, doctor. I'm Helena Taylor and I'm 60 years old.
How you want to be addressed?
Taylor is fine, doctor.
Okay. Mrs. Taylor, I came to know that you have got this bleeding after your changing.
Dr. Manikam, your lot of echo is being produced. I don't know.
I don't know, ma'am. I'm coming closer to this thing. Am I clear now, ma'am?
You're clear, but there's some, like echo is produced with your voice. I don't know why.
I don't know, ma'am.
Okay, no worries. Yes, come on.
Okay.
Continue.
Okay. Sure. Do you have any other concerns to discuss about?
Yes, doctor. I just, from 6 months, I was having some brownish discharge. I ignored it, but then for past 2 months, I thought that this discharge is becoming red, bright red, and now I feel worried. So I went to see my GP, and told me they advised some investigation for me, and they said once the report came, they said you should go to the doctor. So that's why I'm here, doctor.
I'm able to see that you're very anxious, but we are here to support you. And before examining you and discussing the management options, shall I ask a few questions to know more about you? Then we'll have a discussion. Is it okay with you?
Yes, doctor, it's okay with me.
Taylor, please, can you tell me more about your bleeding?
Dr. Manikam, lot of echo. I don't know if other people can hear that echo or not. Because
sorry, ma'am. You can select any other candidate, ma'am. Sorry, ma'am. I don't know what is going on. I don't know, ma'am. Sorry.
Zaid, can you hear this echo as well, or it's my problem?
Yes, echo is there, but I think it is manageable. If you can't, the manage.
If it is very difficult for you, you can ask some other person, ma'am.
Because I'm not understanding what she's saying.
Sorry, ma'am. Anam, can you do it, Anam?
Sorry, what?
Anam.
Okay,
I was asking Anam, ma'am.
Who is taking over? Anam?
Anam.
Yeah, okay, no problem. So, okay, no problem.
Okay, Anam. Okay, so I'll just, restart this one. Because Anam, I can hear properly. But sorry,
Okay, maybe
Manika.
it may be Manikam, she used her phone, that's why she has echo, maybe. Or she maybe used two devices, that's why she has echo.
There is some device problem, I think, either the mic problem or device problem. Anyways,
Or both.
Let's start Anam again, okay?
Yeah, so I'm Dr. and I'm one of the doctor here for a clinic. How can I address your name and age?
I'm Helena Taylor. I'm 60 years old. You can call me Taylor.
Okay. Miss Taylor, as I understand from your notes that you have some bleeding. Can you tell me more about this condition?
Yes, doctor. I stopped having my periods. Maybe I was 52 years old at that time. And then since then I had no problem. But for past 6 months, I noticed having some brownish discharge. And gradually that discharge became red and like a menstruation. So now on and off, I'm having bleeding. Um, I was initially ignoring it, but then I went to see my GP. He did some investigation and he told me to follow with you. I don't know why he sent me here. Is everything okay, doctor?
Okay. So can you tell me when it start exactly, this vaginal discharge, brownish, and then change to red color? When it start?
6 months ago, doctor.
Okay. So did you receive any treatment or anything what was done for you by GP or by somebody else?
No, I did not receive any treatment. I was investigated. They did an ultrasound for me and they told me my endometrium is thick for my age. I'm not sure how much they told me. It's like 17. And they said you need to go to the gynecologist.
Okay. So I will ask you some questions and then we'll discuss your management. Is it okay?
Yes, doctor, it's fine.
Okay. So is there any foul discharge or just staining discharge? I mean, is there any foul smelling?
No, doctor, there is no foul smell. It's just like a menstrual blood.
Okay. So what about your urine?
Everything is fine, doctor. I don't have any problem in my waterworks.
What about your bowel?
That is also okay. Nothing different as such.
Okay. Are you sexually active, Miss Taylor?
No, I'm not sexually active.
Okay. So do you have any medical illness?
No, I don't have any medical illness, but just now your staff, she checked me and she told me my blood pressure is towards higher side, but I'm not taking any medicine for any reason.
Okay. So do you have any allergies?
No, doctor.
What about your body mass index?
It's 30.
So okay. What about your blood group?
Blood group was long time back. It was A positive.
Do you have any rejection for any blood transfusion?
No,
Do you have any surgery?
no, doctor, no surgery done for me.
Okay. Did you have any delivery in the past?
No, I don't have any children.
What about your pap smear? Are you update to pap smear?
Yeah, I did one pap smear 5 years back and it was normal. After that, I did not do.
Okay. So you mean 5 years back you did that one, and after that no follow up?
Yeah.
Can you tell me why you didn't follow up? Still, you are in the system of screening, right?
Just didn't want to. I thought it's not necessary now. It was negative, so I didn't want to.
Yeah, and so we can discuss about it. It's important to follow up on regular schedule for your benefit. So, with whom are you living?
I'm living by myself.
Okay, do you have any support?
I have a business, a small business that I'm running, and I am the only one there.
Okay, do you smoke?
No,
What about drinking alcohol?
sometimes socially, not really.
Okay. So, can I examine you, Miss Taylor?
Yes, sure.
So I will let the nurse to examine your blood pressure, I mean observations, and also I would like to examine your tummy for any mass. Maybe I mean any enlargement in your tummy. Just I will check, and also I would like to examine you from down below. Is it okay in the presence of chaperone?
Yes, it's fine.
Okay, so I would like to examine your tummy, and then after that, I will examine you by a certain device. They call it speculum. It's the same when they do for you pap smear, and then I will examine you by my finger. Okay. So
Okay,
for
doctor.
so for examinations, if it's in long case, doctor, I will go for examinations with them in the mannequin, in the presence of my examiner. So in such conditions, I will maybe he will I mean I will examine I will, if there is any antiseptic, I will use the antiseptic. If there is any gloves, I can use the gloves, and then after that I will be on the right side of the patient. I will ask the patient for permission, and then I will start the abdominal examination, superficial and deep palpation, and then I will do speculum examination with all the proper step for speculum examination, and then after that, I do bimanual examination. Then after examinations, I will continue with my patients I will ask her. So shall we continue? So do you have the report for ultrasounds with your notes, Miss Taylor?
No, I don't have the report, but what I remember, they told me that the endometrial lining, it is thick, it is 17 millimeters. That
Okay.
was concerning.
Okay.
Otherwise, they didn't see anything else which is significant in the ultrasound.
Okay. So it depends whether the report with me at present time in front of me, or it's given by the examiner to me, or I will contact her GP or whatever the process to I want to check the scan report. So when I will check the scan report, Miss Taylor, first I will confirm your name and the age and your hospital number for the report. And I will tell Mr. Taylor there about any normal finding, and then I will explain that, Mr. Taylor, for the result, your womb look like the underlining of your womb. There is some thickness, which is more than it's not normal at present time, the thickness, because usually thickness of the lining of the womb in your age, it will be less than 4 millimeter. Is that till now? It's clear, Mr. Taylor? Miss Taylor, sorry.
Yeah, so is it dangerous to have thick? Because I think I'm not bleeding, so that is why my uterus is thick, isn't so?
So it's this part. It could be one of the cause. That's why we are looking for it. So when it's a huge increase in the thickness of the lining of your womb, it indicate there is some underlying pathology.
Mm-hmm. So is it dangerous, doctor? What I need to do now?
Yeah. So for us at present time, we need to further investigate and to do another what they called it hysteroscopes camera introduced in your womb through from down below, and to see what is inside your womb. And also at the same times, when we can see what is inside, and we can take a small part of tissue they called biopsy, and we'll send it to the lab for them to read, and according to the result of that tissue sample, we can decide your further management. Is that okay?
Yes, doctor. Is there any complication with this procedure?
So this procedure we have to approach. Either we can go for an outpatient procedure, they called fast track procedure. Here in Ireland, we have fast track procedure or fast track clinic. Or if it's difficult or if there is any obstacle for this fast track procedure, we'll go for anesthesia in inpatient. But for the first times, we can try in outpatient procedure. There is some possibility of risk, and we'll explain to you the risk. It could be some risk is difficult to introduce that camera inside your womb, because maybe some restriction of some stenosis in your neck of the womb. It could be some possibility of a trauma, which is rare. It could be there is possibility of bleeding like that. And we can give you patient information leaflets, and we can explain to all these steps of a procedure one by one. Is it clear?
Doctor, so what? Yes,
Yeah.
it's clear, doctor. So what is what are you expecting, that why I have this bleeding, why my womb is thick?
Yeah, okay. So there is different possibility. If it's whole endometrium, if the whole underlying of your womb is thick, so there is possibility it may be what they called it by the medicines, medical term, they called it endometrial hyperplasia, or could be, I can explain, I can draw this, and you can see my drawing in the paper. What is the meaning of all? And if there is localized thickness, could be with that. It may be called polyp. They called polyp, or maybe some sinister changes, but I cannot guarantee what is now until we send that sample and let we see by the camera, we see what is going on. And also we should take the biopsy to know what is the cause behind it. If it's the cause is related to local cause, it could be other causes, concomitant causes or incidental causes related to it, but most likely it's from it's in your underlining layer or the underlining layer of your womb.
Mm-hmm. What you said something about sinister. What do you mean by that? Are you expecting cancer?
Maybe it's 10%. It's 10. One in 10 of women in your age who's complaining of bleeding post-menopause. It could be there is possibility of the underlying endometrial or underlying womb cancer.
That means I'm going to die.
So it's depending according to the result of the tissue biopsy and according to further investigation. We need further investigation and further process to do it to know where is it that suppose if there is a cancer or which type of cancer or which stage where it is separate, if it's just in your womb or it's go far from your womb. And if it's low, they say low or high grade. Sometimes like grade, like something what is graded. They put it in a grade like 1, 2, or 3 according to the grade. And all these parameters, not only just on histopath, and the tissue sampling, we need to do further scan, like they called MRI scan. But from your tissue sampling and from MRI, then we'll decide it, how it's severe that cancer and what is the next step to do for us to try to get rid of this cancer. Is it clear till now? Yeah.
Yes, doctor. Yes, doctor. Very clear. It's very clear. So I can go now.
Okay. Thank you for your time, Ms. Leila. So I think now the discussion will start, right, doctor?
Okay. Can you summarize this case?
Right? Yeah. Okay. So she is a 60-year-old healthy woman presented with postmenopause. So I will use icebar technique usually. It is a 60-year-old healthy woman presented with postmenopausal bleeding. So there is nothing have significant from her background history. It maybe I didn't take further history. I should take further history whether. Yeah, nothing significant. There is no body mass index 30, and there is no. There is no significant medical history of apart from hypertension later diagnosed, and. She's not sexually active and she's nullipara, so it could be that one possibility of her background history. And for the assessment from the examinations, there is a history examination and investigation. From the examinations, null, examination significant. And from the assessment, also ultrasound, there is endometrial thickness, which is 17 millimeter. Which I need in such condition, I need further to go for further steps like hysteroscope and hysteroscope biopsy, direct biopsy.
Okay, so any patient who is coming with postmenopausal bleeding, how you will manage that case?
So we should assess the severity of the bleeding first, and then we'll assess the risk factor behind the bleeding and duration. So for her, she's nullipara. I mean, it is just, I mean, it is grade 1 obesity, nulliparity. From her history, nothing significant. I should look for if she is obese or if she has any irregularity in the menstrual cycle before, which I didn't ask her. I should ask her about previous menses, if there is any irregularity in the menses, if there is any evidence of polycystic ovarian syndromes. And also I should ask her, which I forget in the history, family history, to ask her about if there is any positive family history of whatever cancer, whether it is in the genitalia or whether it's outside genitalia, or the same if she know. And also if she had any history of infertility and if she's received any medical treatment for infertility. This is in the history. Also, so severity, risk factor, and duration. And according to that, we'll go for further. It may be I ask her about urinary, we exclude urinary. Maybe I will do further like urine exam. For bowel, she say there is normal habit. It may be if I suspected, not in this case, maybe in another case, if I suspected from GIT bleeding, I will go for occult stool. And usually it's screening in, I think in Ireland also, in Western society, they have screening, regular screening for occult stool in this age. And also I will ask her if she's postmenopause, if she has a regular for mammogram, because they have screening regular in this age also after 50 in Western society. If she has medical history, nothing, if she's on certain anticoagulant use, whether if she has any medical illness and she use warfarin or other. This I should exclude. And then if nothing related, then I'm concentrated on the genital tract. If there is cervical lesion, vaginal lesion, vulvar lesion, and endometrium.
Okay, so what are the most common causes for postmenopausal bleeding?
Usually is atrophic changes in the vagina and the endometrium lead to the postmenopausal bleeding. Most commonly is atrophic. I think 60 to 80% atrophic changes.
Other than that?
Yeah, other than it could be all it could be like endometrial hyperplasia, polyp, endometrial cancer, cervical cancer, vaginal cancer, and even vaginal, not only cancer, any lesion in the vagina could be. In the vulva, it's cancer or atrophic cancer. Changes in the vulva could be lead. What else? It may be concomitant ovarian with endometrial cancer, like ovarian lesion could lead to endometrial cancer. So local causes in all this area, plus adjacent area, plus if there is any exogenous like hormonal treatment. Maybe she's on HRT. I didn't ask her if she's on HRT, which is important also, because usually they use HRT for certain years. Now they restricted use of HRT for 3 to 5 years. In her age 60, now it's unlikely to have HRT, but I should also ask her about HRT, which I missed.
Okay. So now her hysteroscopy done and biopsy report came to be is endometrial cancer, stage 1, 1A, 1B. So how you will manage this case from here onwards?
Okay, so stage 1B, you mean its involvement more than half? Now there is new staging, I forget really, but according to the Vigo classification. Yeah, so she's more than 50% of the myometrium involvement. Yeah, so in this case, usually after hysteroscopic biopsy is diagnosed, there is a cancer in the endometrium, and then MRI was done for her, and then usually will transfer her to the oncology center, to the oncology. There is a specialized oncology hospital in Ireland. So the team of group, they will decide about her if she is fit for surgery, and she for my case, she look fit for the surgery. Then they will go for. I think it's beyond laparoscope. I don't remember well, but we can go for laparotomy, total abdominal hysterectomy, bilateral salpingo-oophorectomy, with the possibility of lymph node inspection. Yeah, inspection. It could be possibility of lymph node, some biopsy, but I think inspection of lymph node. Then, according to the result after that, they will go, if they need, according to the stage. You mentioned it's, but we need histopathology stage later on also. And according to the type of a tumor, whether it is highly proliferative or low, because I think according to the classification now, there is cancer which is highly, I forget the name. And also it's according to the stage, grade, and then now I think immunohistochemical they use in case of endometrial cancer according to the new Vigo classification. So stage, grade, immunohistochemical, and stage, grade, and type of cancer. Also, all these will decide to go after surgery, will go for radiotherapy, whether it is internal radiotherapy or with or without external radiotherapy, depending on the criteria. Usually, it's on the oncology center, whether they go for brachytherapy down from the vagina, or they go with external radiations from outside, through the abdomen. And usually the regular
Okay, what
follow-up.
if it was okay? What if it was stage 1A1? How you will manage?
Stage 1A1. Okay, for it, we can go for laparoscope. Either, yes, it is on the oncology center. They will go laparoscope, total abdominal hysterectomy, and bilateral salpingo oophorectomy.
Okay, and you can perform it laparoscopically, right?
Yeah, for early stage the laparoscope.
Okay.
There is facility, then we go.
All right. So what will be your follow-up plan for this patient?
Yeah, so this patient usually needs follow-up. I think in the first 2 years, they need every 6 months in the first 2 years, maybe every 3 months in the first 2 years, and the second 3 years every 6 months, and then at that annually. So in the first 2 years every 3 months, in the after that for another 3 years every 6 months, and then annually. Usually they will go for a follow-up in the same oncology center by history examination. If they need any further, like if there is any suspicion, maybe go for CT scan.
Okay. So if you diagnose this in a young patient, how you are going to manage it?
Okay, so you mean stage 1A?
Yeah, stage 1A, it's a young patient who want to keep her fertility intact. Then how you will manage?
So in case of such stages, usually because of they want to keep their fertility wish, and such conditions could be use of progesterone, a progestinic agent like Marina, and with regular follow-ups. When they complete, when they saw some regression, I think they will go for fertility, like assisted reproductive technique. If it's early and after a multidisciplinary approach, if there is possibility for such condition, they will go for Marina and regular biopsy after 3 months, and then another 3 months. If there is some evidence of regress, maybe they will go for ART. Otherwise, now with advanced technology, it maybe they will discuss the options of retrieve of her site retrieval. I will, and for further, maybe if they use it for surrogate later on. They will discuss with her different options.
Okay, and what is the survival rate of endometrial cancer?
Well, it's a good prognosis, cervical cancer, especially if it's less invasive and early stage. It's good prognosis, maybe 90, above 90, especially in the early stage. And according to, as we mentioned, stage, grade, and type of cancer.
Okay, just final question quickly. Can you tell me any risk factors for having endometrial cancer?
For this lady, doctor?
In general?
In general. So it is obesity, HRT, especially estrogen only, but it could be combined, but mostly estrogen. Was it maybe there is polycystic ovarian syndromes with irregularity in the cycle of the endometrial hyperplasia. It could be. I think smoking reduce the risk. Hypertension, diabetic, maybe. Concomitant family history. There's family history of Lynch syndrome. It may be.
25 minutes finished. Okay, just quickly, protective factors.
Sorry, doctor.
Protective factors for the endometrial cancer.
Okay, protective factors. So it's a COC. It could be lactation. It could be increased parity. Could be protective factor for it. Yeah.
All right. Okay.
Any-
Thank
any-
you so much, Dr. Anam. Thank you very much. You did very well. Anybody want to comment? Zeb?
Yes, I do have some comments actually. If Anam would
Yes.
allow me to say something, I would definitely share my feedback. But of course, you know,
Yes.
as a whole, she did good, and you know, she did try to dig out history, but somehow, you know, I felt the lack of sympathy when you said, or the patient said, that am I going to die? So she was pretty blank at that time, and she just said that, you know, maybe, you know, one, you know, the blah blah blah. Okay, so I think, you know, we shouldn't be saying somebody that you can die at the very moment, in the very first consultation. You can simply say that, you know, look, I mean, having such, you know, the problem, or having such, you know, the biopsy result doesn't makes you you know, the on the verge of, like, I mean, you can die, you know, the anytime, but we are going to see. Okay, like you said in the end, that cervical you know, the this uterine cancer has a very good prognosis. So similar, you know, the same thing you can tell it to the patient as well. So I think, you know, the that should was miss that was missing. And another thing was that, you know, time management, when you know, the because she kept on repeating one thing, that in Ireland we do this, in Ireland we do this. No, 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 we shouldn't be saying that, because, you know, we are in exam hall, we are in exam center. Anyone who is present in Ireland or outside Ireland is aiming and going for this exam. So we shouldn't be repeating this thing. So I think, you know, this should not be done. Okay, Anam, are you there? Hmm?
Yes, doctor, I'm listening.
Yes. So I think, you know, if you can minus this thing, otherwise I like you very much. You know that, you know, your tone is good, your pace is good. You know, there is, you know, your communication is flowy, everything is very good. So just, you know, the minus these things, I think, bring little bit empathy in your, you know, the tone, and of course, you know, the few, you know, the kind of soothing sentences or words to a lady who is single, who is having postmenopausal bleeding, who is 60 years of age, and, you know, who is having all these problems. And yes, examination part, I think Dr. Uzma will comment on that. So I also
Yeah.
have some.
No, I
Yes,
have
yes.
few other comments as well. First of all, Anam, of course, it is a very nicely done station with few things missing, but overall it was a very good presentation. Plus, am I audible?
Yes, yes,
Yes,
yes.
doctor, yes.
All right. And, you know, your confidence level, your the knowledge part is good. I think it's very obvious that you have the knowledge. But as Zabe said, the empathy in your tone was missing. Okay. And then you were very quick. You went to the examination. Your history was, you know, not complete. In exam, you have to take history. Then you later realize yourself that you did not ask this, you did not ask that. So if you miss so many things in the history, then it will not be easy for you to pass the exam. Although it is very obvious that you have all the knowledge of endometrial hyperplasia and endometrial cancer and a postmenopausal bleeding, you know how to manage it. But as I said, in the exam, there are marks for each and everything. So your history, you did not ask about any HRT if the patient is on. You did not ask about if she's having pain anywhere, right? You ask about urinary systems symptoms. You ask about bowel symptom, but you did not ask about any pain or weight loss, right? Then you just forgot about family history completely. Then you did not dig at all that she doesn't have any child. You should have asked. No, I told you that I am not sexually active. That means at present, was I sexually active in my past and didn't have any children? So that part, you know, that leads to one thing leads to another. So this
Yeah,
is one thing.
I asked you, doctor, about did you have any previous deliveries?
Yeah, that's what I'm saying. Previous delivery, but not sexually active. Why you didn't have? Did you do anything? Did you consult a doctor? May I ask you, if you don't mind, why you didn't have children? There was any problem with you?
Yeah,
Any
yeah.
medical problem?
Yes.
You have to go a little dig deep into that. Then in the examination part, you came directly to the abdominal examination after BMI. You forgot about the general physical examination, which
Anemia. Anemia.
anemia, neck swelling, pallor, hand, everything you need to talk about. And then you have to come to the general abdominal examination and the vaginal examination. Okay. So these were the few things which I felt should have been addressed. Screening, it's very good. You talked about mammogram and colonoscopy, which should be done routinely. And of course, uh, this part of the world, this is a screening test. You could have asked about that also, that are you doing, because she missed on her pap smear as well. So did she do the other screening test? She did not do. So those things were missing in your history. Then, yes, Sandhya, you liked her tone. I also like her tone very much. And Anaya, yes, she did well. So now coming back to the station, this is a repeated station, okay? And almost same questions are asked each year. So let's go. What they ask you first, they want you to summarize this task. Okay. So, and what I told you about this ultrasound from the beginning, but my role player, this was my exam station also, and my role player did not tell me about any ultrasound. And then once I asked her, did you do any? Because I was lost, and there the age was mentioned 70 something. It was not mentioned in years, it was mentioned in like 19 something written. So once I calculated, it reached about above 70. So for me, the mind was going towards ovarian cancer, not towards endometrial cancer. But once I asked her, did you do any investigation? Then only there was an ultrasound report which just said that this uterus is bulky, ovaries are not seen, and the endometrial thickness is 20. So then the examiner asked me why ovaries were not seen. I said maybe because she's menopausal and atrophic ovaries, so that's why they are not seen. But then they started, okay, what you will do further. So of course you will do stereoscopy. So then she said, okay, now it is stage 1A1, how you will manage. Then you have to tell that is the treatment is total abdominal hysterectomy plus BS. So then she asked, can you do it laparoscopically? I said, yes, if the expertise are available, you can do it laparoscopically. Then what will be the follow-up plan? And that was all about. And she asked me, what are the causes of postmenopausal bleeding? The same questions which asked Anam now. These all were asked in the exam. So if you leave a long time for the examiners to ask questions, what do you think will happen then?
You will ask till the end. More and more
That
complicated.
they will roast you like anything because you are giving them the opportunity of 10 minutes to grill you, right or wrong?
Yes.
So try to take full 10 minutes in your history and then take 5 minutes for your examination, and then okay, give them 10 minutes where you will summarize the case and then you will discuss. So that will be more than enough, because two people are sitting there. One will comment on your history taking, one will give you marks on your history and examination, other one will give you mark on your case discussion. Okay, so that is very, very important. Don't rush into the history. Don't finish in 3-4 minutes your history and come to the examination, because then you're giving a lot of time for the question answers. And if they start, it's a non-ending story. You start digging your own grave. Okay.
Yes, doctor.
Okay. Thank you very much, Anam. Thank you so much for coming forward and taking the task. Okay. Anybody has any question about the long case? Okay, who is willing to take the next task? Osce, 10 minutes task. Small one only. Come on, girls. You saw Anam performing, now you can take it. Girls, and I don't know if any guys are there. So please come forward. Okay, because here if you go to this one, this is again from the their guideline algorithm, how you follow postmenopausal bleeding in Ireland. And then these are the different etiologies which Anam covered nicely. And yeah, we know that which patients are at higher risk. So patients on tamoxifen, patients with Lynch syndrome, PCO patients, patients with obesity. This is from up to date, okay, and it covers nicely everything. Everything same is there. Then what are the protective factors? And just, it is very strange that smoking is a protective factor over here. That's very strange, but yeah, it is. But don't start smoking just because you want to decrease your risk of having endometrial cancer. It has many other risks
Although it is very tempting.
associated with it, okay? So then this is the staging. Okay, they expect you to at least know the main stages. So stage 1, then 1A, B, C, 1A, 1. So the basic treatment, stage wise treatment, they expect you to know in the exam. So please prepare yourself with the stage wise treatment. Okay, so this is the presumed stage 1 should involve peritoneal washings for cytology, hysterectomy with BSO, and if they have deep myometrial invasion, which is suggested on the MRI, then you can do pelvic and periaortic sentinel node, or if it is more than that, then you can do a full lymphadenectomy. Okay, so this is the confined, as I said, it is uterine, confined to the uterus. Then with or without shows, these are again TH and BSO, and it can be done laparoscopically, it can be done robotic also. And if there are other risk factors, you are expecting something more than that, then you can go for a conventional laparotomy and perform a TH and BSO. Okay, for stage 2 and 3 tumors, of course, it will be peritoneal washings, hysterectomy, BSO, pelvic lymphadenectomy, bilateral, omentectomy also can be done for such patients. Depending upon what you see inside, you will do the needful at that time. If in an advanced stage, then you have to perform a pelvic radiotherapy for palliation symptoms. Appropriate surgery can be considered later. And of course, it is not your level, it is a higher level. MDT is involved in that, and it is the oncology people who take care of such patients. But you should know the follow-up plan and which patients to send to the oncology people and which patients can be done by the general gynecologist. This was also one of the questions, that who will perform this case. So stage 1A1 can be done by who? No, yeah. Local means the simple gynecologist. Yes, correct. All of you are correct. Okay. So you people don't want to volunteer for the next case, then we will not do it, because if nobody want to perform that, there is no point of doing it, right? Girls, come on. Let me know.
I think everyone is shy.
No need to be shy. We are just discussing over here. We are not judging. Next time, Madam Sandhya, next time, she's waiting for next time only, huh? Okay, if you people don't want to do it, it's fine. So we'll leave it. We'll, do it in our next session. I wanted to do this station, which came in this May exam. But okay, it's fine if because this webinar is for you people to participate. If you will not participate, then there is no point of me just giving you a lecture. Based on the performance, it is just like a discussion. It's not a judging someone or giving marks to someone. It is a discussion for the exam sake. So if you people are not volunteering, so it's fine. We can do it in our next webinar. So any questions for the previous case? At least ask questions. Very good sessions. Thank you so much. So sweet of you. Okay, thank you very much. Anybody has any question about the exam, about the pattern, about topics? Please feel free to ask. Thank you, Razia. You were able to listen to us during your clinic. Thank you so much. Okay, so basically the MRCPI OSCE, it's a, knowledge-based exam. In MRCOG, you will get some marks from here and there based on your communication skills and your body language and these things. But in MRCPI, it's totally knowledge-based exam, okay? So if you don't have the knowledge of the topic, you won't be able to pass this exam. So make sure that once you're going to the exam, you know the topic hard, like everything you know about that topic, and then it's not a problem. And it's a repeated recall type of exam. So if you are prepared well, you have done most of the recall stations in your courses, whatever courses you people will take, it is going to be very beneficial, and it is going to be very easy if you are prepared well. If you are not practicing the station with someone, then it is going to be difficult. So that is why, the aim of these free sessions or taking courses is that you should be able to speak. So if you don't speak in the free webinar, then it is more difficult for you to speak on the exam day. So try to take benefit and, participate in these free webinars.
Exactly.
Yes, Razia, sure. Thank you very much. Dr. Zeb, do you have anything to tell them for the guidance?
No, the same thing, practice, 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 because practice is going to, be the key to pass this exam or to pass any exam. In fact, the OSCE or the long cases and everything, it just needs loads of practice. That's it. So if I mean, all the time, the any candidate is going to be shy, not, the performing or not performing well at all. So I'm sure, that is going to be difficult by the end of the preparation, because we have to kill our hesitation now so we can perform well in real exam. So that is the main theme of all free webinars, as well as, the courses as well. So I think, it's a good idea that you practice, and it's a good idea that you present to someone who can correct you, because knowledge is everywhere. Notes are everywhere. Everybody knows what is the theme of exam. Everybody knows how this exam or any exam is going to be. The main idea is, the focused correction and focused guidance. That's it. So we aim to give, the focus guidance in terms of that, we can the guide that what are the important topics to focus on, what are the important guidelines to revise from, and what are the exactly points that, you can the focus to crack this exam in one go. And our aim should be to crack any or, this exam in one go. Okay, so you have to prepare with full throttle, 100%, give your 100% input. And of course, nobody is sure about the result, but yes, one can be sure of the hard work. One can be sure of the the all the efforts that have been, the put in into the preparation and all. So I think, the start doing preparation from now on, because July is about to end, and then, the 3.5 months are going to be enough to go for November OSCE. Okay, because MRCPI exam centers, they don't give us plenty of time, to think about, to go about, and to prepare. And they are just going to send you an email that okay, you are invited. And if you are not prepared, so yes, like Dr. Uzma said, that it's a bit costly exam. So you have to be the on top of everything, that before the going for this exam, you are fully prepared, and everything is in a kind of the streamlined. Okay.
Yeah, and one more thing I would like to tell all of you, that whatever course you people take, please attend the live sessions of that course. It's very, very important. Running after templates and collecting material, it is the most useless thing you will do. You will just waste your time, because you don't have all the time in the world to go through the 100,000 templates you have collected. Okay. What will make you pass is your performance in your sessions. That will give you confidence. That will make you identify your mistakes and your strengths. Okay, so that is very, very important. I've seen people that they are coming, they are taking, maybe they will take 3-4 courses together. Just they want to go through the templates, the material provided by those courses. It is totally useless. Okay, you have to perform, you have to attend the live sessions, and do the sessions with the mentor, because the persons who have passed the exam, who have there in teaching for quite some time, they know what are your strengths and where we need to work on you. Okay. And unless you speak, nobody will know what is your strength and what is your weakness. So that is very, very important.
Exactly, exactly.
All right. Thank you very much, everyone, for being with us. And hopefully, we'll come up with another webinar. And I hope that that day people will come forward, volunteer to perform, because this is for you people. If you don't volunteer, then we cannot do anything about it. Okay. We cannot do the exam in between me and Zeb. It has to be you. Okay. All right.
Otherwise,
Thank you very
we would
much.
love to, because me and Dr. Uzma, we both have been study partners.
Yes.
We have practiced a lot together.
Yeah, we will go back to our that
Yeah,
time.
our student life.
Yeah,
Anyway,
student
thank
life.
you so
Anyways,
much.
we are
Thank you
still
so much, Dr.
student.
Uzma. Yes, it was wonderful.
Okay. Thank you so much, everyone. Thank you. Thank you, Zeb. See
Thank
you
you.
soon
Thank
in
you,
another
Dr.
webinar.
Inshallah.
Thank you.
See
Take
you.
care. Night. Bye-bye.